So let's look at the introduction to pharmacoeconomics. So pharma pertains to drugs. Economics pertains to a social science that I think most of us are familiar with. So we are going to review the basics of economics. And then we're going to look at the unique features of the relationships that economics and health economics have. And we are going to eventually define pharmacoeconomics. And then we are going to list the types of pharmacoeconomic analysis. So these analyses are a backbone of this subject. You need to understand the pharmacoeconomic analysis. Now, this is one subject that perhaps is not well founded in this country, but these are the kinds of skills that are going to make you work for the National Health Insurance Authority. So you're not going to say, no, I do not have an idea about insurance. I never learned this. I don't think it will go anywhere beyond this. The best you can do perhaps is to specialize in pharmacoeconomics at a postgraduate level. But even with your undergraduate, you are going to have the necessary skills to work in the National Health Insurance Authority. Okay, so what are the basics of economics? So economists have a notion that everything in life is connected. All events in life are connected. And that there are many types of rules that affects resource allocation and distribution. I'm sure you know the two sides of political theory, the socialist and the capitalist approach. The socialists will favor government intervention in the allocation of resources, like centralizing most of the services. But the capitalists, this is an applied science. I just want to have your ideas. If you look at Zambia, what are we? Are we capitalists or socialists? From your own understanding. Because some of us are going to be politicians, but will not have an ideological standing. In the West, they say you're either on the left or right. So in Zambia, are we socialists or capitalists? Who can give it a try? From the way you look at our governance system, what are we? Because this determines the type of rules that we follow. Yes, I need an answer.
I think we are capitalists, sir.
Okay, well, yeah, because we believe in free markets, right? But the challenge we have is that our private sector is so small. Therefore, you find that government has a hand in quite a number of areas. Sorry, I've gone. So economists have a notion also that we always want more than we have. I think this is true, even at our domestic level. We always want to amass more than what we have. And then the nature of resources. Resources in this case can be monetary, it can be land, it can be minerals. You find that all resources, whichever they are, they've got more than one use. And then it is true that different resources are going to appeal to different people. So the way we use resources is quite different. The opportunity cost. So this can be defined as the best value for a foregone option. So you find that we always give up an alternative, given two alternatives for the other alternatives. For example, a doctor would rather work overtime in the emergency room, but that time can be used to write up his thesis for his postgraduate degree. So the concept of economics is that we have to give up something for something else. Why? Resources are not finite. Resources are always limited. So let's look at economics versus health economics. So economics in societies is a study of allocation of scarce resources that satisfy our demands, our daily demands. But health economics focuses on how scarce health resources can be allocated so that medical services can be provided. So when you look at private markets, it has been shown that they are efficient and they always allocate resources efficiently than public markets. So in short, they maximize the limited resources. Now let me give you an example. The pharmacy structure in Zambia, 90% is public sector based. But in the Western world, it's the opposite. So for example, in Zambia, you have to go to a public hospital. You'll be given a prescription and then you go to the hospital outpatient pharmacy department. Elsewhere, pharmacies are just reserved for institutionalized patients, patients who are admitted within the facility. If you're an outpatient, you'll be given a prescription and you go to the private pharmacy where you simply present your card. Then the pharmacy will save you. And then at the end of the month, the government is going to reimburse to pay that pharmacy for the services it will have rendered. So in this case, Western governments are using private pharmacies to efficiently distribute resources. Now, the commonest challenge in the public sector is shortages. This is a reality. This reality was realized by our friends a long time ago, and they've devolved, right? It's impossible to go to a private pharmacy and find that something is out of stock. Why? because that's a private entity. Out of stock means an impact on the profitability. So the way private markets efficiently allocate resources is that they always focus on profitability. Therefore, you find that medicines will forever be available. But in our situation, you have to look at the whole bureaucracy, right? A centralized distribution system that is plagued by challenges. Transport, it can be human resource. So when you graduate, don't go with a notion that really, like I've said before, everything I learn in pharmacology will be a bed of roses. No. You have to realize that because of our economic system, the way we distribute resources, certain things are inherent. There will be challenges. Don't shun challenges. Your role is to manage challenges rather than shun them. So when we talk about efficient mechanisms, I'm sure those who are practicing, you know, we've got art centers in selected facilities. You've got chronic conditions. So these are the kind of services we should devolve. This is what is going to decongest our hospitals. Now, life being what it is, I might be teaching you today, but our destinies are different. Perhaps some of you will be authorities in future. You'll be heading these institutions. So these are the kind of ideas that you should fuse in and change the paradigm. I'm not hearing an amen today.
Amen, sir.
Amen.
No, you are too late, or maybe you didn't get me. No, it's a reality. Some of you are going to have these positions. Please change the paradigm. All right. So what's the definition of pharmacoeconomics after having dwelt on the basics? So this is a discipline that identifies. It will also measure and it will compare the costs. What are these costs? The cost of procuring these drugs, providing these services, dispensing services, as well as the consequences that pharmaceutical products bring about on the services that are on offer. So these are the types of pharmacoeconomic analysis. The first one is cost minimization analysis. So in this scenario, we look at two alternatives that are identical. For example, let me just simplify this, but we are going to look at the detail later, but not today, of course. So for example, you've got two medications. You've got glibenclamide. I'm getting a feedback. People should learn to mute their microphones. You've got a condition, diabetes mellitus, and you've got glibenclamide, which is an oral hypoglycemic, and you've got insulin. They both have a cost in terms of acquisition, and they both reduce blood sugar. So in terms of cost minimization, or maybe let me not give an injectable and a tablet. Perhaps glibenclamide, if I give metformin, okay, for argument's sake, let me choose metformin and glibenclamide. They will both reduce blood sugar by a parameter, which is blood glucose, by a certain value, like reducing it from 12 millimoles to 5 millimoles. Okay, so to determine which is the best drug in terms of cost, for example, if glibenclamide is responsible for reducing blood sugar more significantly than metformin, we are going to choose glibenclamide. Assuming glibenclamide is costing less and metformin is costing a bit more, it means we'll choose glibenclamide because it's the least cost and it's the most effective of the two alternatives. Okay. Now, for those who are going to work in private hospitals, these are the kind of analyses that are not done. Hospitals are just informed by medical sales representatives on what is latest on the market. Boom, you buy. What are you doing? You are increasing the cost. And in increasing the cost, what are you doing to yourself as a pharmacist? It is highly unlikely that if the hospital is spending so much on drugs, even your emoluments are going to be improved for the better. No, management will just give you an excuse that no, we are incurring a lot of costs. Okay, so this is an opportunity for a pharmacist to make a change, to convince management that we need to stick to the national formulary, the essential drug list, so that the hospital can reduce costs, so that the hospital will be able to increase your salary and meet any other incentives without difficulty. Okay, so sorry, I had a disruption. Just a minute. Okay, so that's the essence of doing these evaluations. We also have the cost effectiveness analysis, where we look at the natural health units. So these natural health units, examples that we can see here, we've got blood pressure, blood glucose, successful treatment, cure, for example, forced expiratory volume in asthma. This is a parameter that is used to evaluate the effectiveness of asthma medication. We can also pick symptom-free days. So these are the parameters, the natural health units that we can use to evaluate medication that is cost-effective. We also have the cost utility analysis. It also uses natural units. But the cost utility analysis is much more concerned with the quality of life. that the patients will experience as a result of drug therapy, as well as the added life years, for example, in the treatment of cancer. And we also have the cost-benefit analysis, which uses monetary units, but the only difference is that in this analysis, we can use multiple outcomes to make an analysis. Now, this is just an introduction. The bulk of the lesson, the bulk of the topic is going to be spent on these four. Now, for us to understand these four, modes of analysis, we have to understand health outcomes first, and then we also understand costs. No, now let's start with health outcomes. So for every medical intervention, there's an outcome. Now these outcomes can be positive or they can be negative. For example, if you're going to give artemisinin in malaria, you expect malaria symptoms to subside. If you're going to give chemotherapy in cancer patients, you're going to have a lot of negative side effects. Now we are going to see how these types of outcomes impact on the cost. So in pharmacoeconomic analysis, there's a cost of acquiring treatment or intervention. So each treatment that is given to patients in the hospital setting, there's always a cost. And for private hospitals, they are constantly monitoring these costs, but they don't have skills that can reduce the cost of them acquiring drugs. Why? Because pharmacists haven't come forward to say we can make a difference. Remember that in the healthcare system, depending on which setting you are in, the drug budget is about 25%. So that can be quite significant. So now, in health outcomes, well, the outcome is measured against the treatment that is provided. So we'll have an input in all the four basic pharmacoeconomic analyses we looked at. There's always an input measure, which is the cost. And then these analyses differ on how they are measured and handled. We're going to look at that later. So for example, the output in the pharmacoeconomic outcome can be the number of cases cured, as we saw earlier on. Now, besides the outcome, we also have the health-related quality of life as a concept. So this is related to the subjective outcomes like the physical state of the patient, the mental state, the emotional state, as well as the social functioning. Now, these are what the patients are going to experience. We can also look at successful outcomes, also the number of deaths, the number of symptom-free days. For example, if it's asthma or allergy, we can also look at the drop in the clinical parameters. For example, in cancer, if the drug is able to reduce a tumor, we can take that as an outcome and we can measure the cost of that outcome. There's also what is called the quality adjusted life years. Now, these concepts will help us understand the pharmacoeconomic analysis, the cost utility analysis. So now, this is what is called the QALY. The QALY will help us present the value of the health outcome. So in this case, health is the function of the length of life, which is quantified as a quantity. Besides the quantity, we also look at the quality of life. So the quantity and the quality of life have to be combined into the single indexed number. So the QALY is multiplied by the utility value. The utility values are determined by the methods that we'll see later on. And then that multiplication can help us determine the health outcome. Now, how are these utility values arrived at? So these are arrived at by using the rating scale. You can also use the standard gamble. You can also use the method called the trade-off method. Now, in you understanding these concepts, you should realize that these are mathematical. So in most cases, you'll not be asked to calculate the value on the rating scale or the standard gamble. No, these utility values will be provided for the purposes of you calculating. So let's look at how the calculation is tackled. So one QALY, for example, will represent a year of life lived in perfect health. Okay, so every year that is lived in perfect health is equivalent to one QALY. Just understand that relationship. I know you might ask, but how are they arriving at one? No, this is a predetermined relationship. If someone lives a healthy life for a year, it's equivalent to one QALY. And then you multiply by the utility value, which will be given. It will have been determined by these determinants, these methods. So a QALY is measured from the scale of 0 to 1. Okay. And then for perfect health, you give it a value of 1, like I said. And then let's move into the example. For example, if 3 years of quality life, perfect health have been lived, okay, and the utility value is determined to be 0.1, it means that 3 multiplied by 0.1 is going to give you 0.3 QALYs. Now let's look at another example. So if half a year has been lived in perfect life, we can multiply it by the utility, okay? And then death is always assigned the value of 0 QALYs. Now, the fact that we are finding decimal values, so 0.3, for example, is far away from 1, right? So when you're interpreting the outcome, this is not a very good outcome. So in cancer disease states, your QALYs will always be closer to 0. But when you look at allergy, for example, it might be a flu, it might be a skin reaction, if you have to calculate the quality, if you have to calculate the outcome in short, you find that the value will always be closer to 1. So this is how you determine. We'll look at this in more detail when we look at the actual method of economic analysis. Okay, any questions at this point? Oh, we have understood clearly. I'm happy. No questions? Hello?
Hello, so
Yes, yes. Do you have a question?
no, it's clear, sir. Like today I'm following, so I'm following.
You are not following in the last lecture.
That one, like the one who that last Friday, it was bad, sir.
Or
The network was bad.
all
Yeah,
right. Okay.
yeah, sure.
All right.
Thank you.
Okay. I'm glad it's clear. Anyone who is not clear? Okay, let's move on. We've got little time before we are locked out by technology. Let's look at the costs. So what are the objectives? To explain why costs are calculated. In case some of you were wondering, but why should the cost for a good outcome or a bad outcome, why should it be calculated? That's the idea. Then we are going to enumerate the types of healthcare costs with examples. And then we are going to explain why the perspective is important. Okay, let us take a break. So in dealing with costs, we're estimating the resources that are being invested into the production of goods and services. Well, that's very sad. So we are estimating the costs, or we are calculating the costs that are invested into the production of these goods and services. Now, the nature of costs is that there are many types of costs. So this is the reason why costs are measured, and the type of costs are categorized as direct medical costs. There are also direct non-medical costs. There are also indirect costs, and there are also intangible costs. Now let's look at each of these costs one by one. So we have direct medical costs. These are costs that are borne by patients, as well as payers of health insurance for the diseases that they are treated for, or the interventions that are made. So, as well as the side effects that can be managed, for example, in chemotherapy. So these costs can include costs that have to do with the acquisitions of medicines, or the cost of medicines, the devices, the diagnostics, as well as the physician visits, as well as hospitalizations, as well as any other associated payments. So these will be directly related to the medical costs. The others are direct non-medical costs. Okay, so these are costs that are not of a medical nature, but they are associated with costs of treatment. For example, the cost of traveling to the hospital to obtain that treatment. If you are using a car, you are going to bear the fuel costs. If you are using public transport, you are going to bear the cost of the ticket that eventually goes into the acquisition of fuel. Some hospitals will charge for parking slots. Some hospitals will also have childcare services whilst you are visiting. So these are not related to medical costs directly like we saw, but they are associated with treatment. The other costs are indirect costs. Now, these are costs that can be associated with loss of productivity due to illness. Okay, for example, if you are giving care, you are away from your workplace, productivity at your workplace is being lost, and the company is costing that as a loss for the disruption of you giving the company the services they hired you for. Now, when we discuss costs, we should look at the perspective. So the perspective simply tries to look at whose costs, right, are the costs based on for the purposes of you making a pharmacoeconomic calculation. Okay. So this perspective can involve or can look at the society, the people, as well as the payer, who is the health insurance, as well as the caregiver, who is the hospital, and the patient. So you have 4 perspectives. So these costs that we've just looked at whose cost are they? Is it from society? Is it by the insurance company, or is it by the hospital, or is it by the patient? So, for example, from the societal perspective, all medical and non-medical costs are relevant, right? You as a patient, you feel the cost of paying for that ticket, the cost of buying that fuel, as well as the cost of, receiving that treatment. However, from the perspective of the health care insurer, in our case, NIMA, the National Health Insurance Authority, certain categories of costs will of course not be relevant, all right? So NIMA won't care about, your non-indirect medical costs like your transport costs, no. From their perspective, the only cost that they will care about is the direct medical costs, the actual cost of treatment, and the actual cost of drugs, okay? We also look at the concept of marginal costs. We are building on to the pharmacoeconomic analysis. It's important that we break down this rather than find them in the pharmacoeconomic analysis. The understanding might be a bit difficult. We are going to spend a lot of time. So there are also marginal and incremental costs. For example, if treatment A offers a better outcome at a higher cost than treatment B, okay, obviously we are going to go for treatment B despite it fetching a little bit more. So, but what we should realize is that we need to determine whether the added benefit is worth it. All right. You would also look at incremental costs, for example, in chemotherapy. The use of chemotherapeutic agents to treat certain kinds of tumors will bring about a lot of side effects that will require additional costs to treat. For example, if you're using folate antagonists, you require to also dispense hematinics, that is folic acid, and some other advanced hematinics. So the cost of giving treatment that is beneficial can result into a marginal or an increase in costs because you have to treat other outcomes like side effects. There's also another cost called the intangible costs. This is intangible, you cannot feel it. Okay, so for example, pain can be quantified as a cost, as well as fatigue, even anxiety, because these can affect productivity. And then the only problem with intangible costs is that you cannot convert them into monetary units. They are very difficult to quantify in terms of money. So in essence, they are very subjective. I think we'll end here because we need to spend more time on each of these 4 economic analysis. Any questions at this stage? Do we have any questions?
No question, sir.
No, now I'm so shocked that this new concept can be very clear. Are you sure it's been very clear to you?
Sir, hello.
Yes, I can get you.
Yeah, I think some of us is the network is very bad. We've been locked out, and so starting from cost, you have like this is now when I can get your voice clear. So the network is too bad that we can't hear you. We can't see. I can't see the slides. So that's why we can't even. I can't even ask the question because I've not understand anything because of the network. So I think it has been bad today. Anyway.
All right. Okay.
So
It will
that's
be
the question. Yeah.
okay. Sad. Technology will always have hiccups, but it will be compensated in your notes. The presentation is derived from the notes, but you can ask questions even outside class. Okay, so we'll look at let's just have a look at what we'll look at. The cost minimization analysis and the cost effectiveness analysis. Then we'll look at the other 2 that we briefly looked at in our introduction. Okay, then we are also going to look at calculations, how to evaluate these costs so that we have the skills of how we can convince the institutions we might work for on how pharmacists can have a role in reducing the overall costs, the overall medical costs, whether you are at a private hospital clinic or whether you are working for the National Health Insurance Authority. So the National Health Insurance Authority is a new concept. It's just starting, but going forward, there might be opportunities for pharmacists in the near future. Okay, thank you very much. We'll see you. We'll meet on Friday.